It's now my pleasure to introduce Dr. Nicole Scott. She's a board-certified OBGYN and associate professor at Indiana University School of Medicine. She's been on faculty there since 2013 and has served as a residency program director since 2019. She obtained her menopause certification in 2024 and is currently helping women through menopause transition with evidence-based therapies and validation. So please join me in welcoming her.
Good morning, everyone. Thank you for the invite. So just a couple of disclosures before we get started. I have no financial disclosures. Next is we'll talk in terms of women, but we understand that gender identity is a spectrum. So when I refer to women, it's going to be people that are born with uterus, but I will use that gender terminology. And 3, there is really not much out there for sickle cell disease. And so what we're using is kind of our general guidelines for menopausal hormone therapy, kind of best practices, and kind of extrapolating that to your population. But there is really very limited data out there. All right, so here are our objectives. So we're going to kind of talk about unique things to the menopausal transition and how it may relate to your patients, understand potential risks and benefits of hormone therapy, and we're going to kind of go through some cases to kind of put this into play for your clinical practice. So just some basic definitions to start. So what is menopause? So classically, it's going to be defined as a cessation of menstruation for 12 months in the absence of other reasons, hysterectomy, menstrual suppression. The average age in the United States is 51 to 52, and when I was looking through the literature to see if we had numbers for the sickle cell disease population, there's really not out there with the exception of suggestions of going through menopause earlier due to hydroxyurea, or certainly if they've had transplant and have undergone chemotherapy for that. Menopause is normal, but it can be quite disturbing. As I look around the room, we have a lot of X chromosomes here, so if you guys haven't seen it yet with your patients or experienced it yourself, you will. Perimenopause is this ill-defined period, anywhere from 5 to 10 years before the last menstrual period. There's really not a time definition on that, nor any way to kind of detect that from blood. It's really based on clinical symptoms, and so should be on your radar, particularly in the transition, the kind of age group. I would say probably 35 to 50. It should be something to consider. There are many symptoms of menopause. Classically, we think about sleep disturbances and hot flashes, but we know that estrogen affects every single part of our body, and we have estrogen receptors everywhere. So other symptoms that are often reported, but are very hard to quantify, would be some cognitive changes. Women classically report this brain fog and this kind of difficulty with word finding, executive function. What they used to be able to do at work and within their relationships has dramatically changed. We see an increase in mood disorders with increase in anxiety and depression. We see an increase in autoimmune conditions in the fourth to fifth decade of life. We have metabolic changes. So we see an increase in insulin resistance, an increase in hyperlipidemia, which is going to shift their cardiovascular risk. And again, we'll talk about hormone therapy in that context. So it really affects a lot of your body. And when we think about women with sickle cell disease, we know that pain is often a symptom and a manifestation, but we need to realize that they could be having pain for other reasons, and their sickle pain may be potentiated by this menopausal transition as well. This slide is really busy, and I only put it on there so you guys understand what's happening in this perimenopausal period. So if we look at the top graph, this is a measurement of estradiol, which is the solid black line, and then progesterone, which is the circle. And you can see this is their menstrual cycle, their day of their menstrual cycle on the axis. And you can see those estrogen levels swinging so wildly. So classically, in our reproductive years, our estrogen is high at the beginning of our cycle. Once we ovulate, our estrogen falls. What's happening in perimenopause is this loop event, so luteal out of phase event, in which this is where our FSH and our estrogen are all over the place. So we're having very high estrogen levels in the first half of our cycle. We're having them again in our second half of the cycle, and they're swinging rapidly, and this is contributing to all of the symptoms. I also put it on here so you understand that a blood test is a point in time, and you can see just day to day, our numbers can vary widely if we were actually to check estrogen levels. So there's really not a lot of utility in checking estrogen levels. We really treat and follow based on symptoms. So how do we diagnose? The first thing is we want to believe women. So we want to kind of put it on our radar, especially for those 35 to 50-year-olds, that something hormonally is changing. And if you see worsening symptoms or worsening manifestations of their other comorbidities, really think about menopause in this space and something that we could address that could ease other symptoms. We certainly want to take a history. For us, the last menstrual period is like a vital sign. So if your periods are regular, that's generally a good picture of your health. If your periods are irregular, exploring other reasons for that. And then certainly in your 40s, your periods are going to become irregular, and this is often the first sign of these hormonal changes. So if a woman's menstrual cycle is becoming more irregular, typically shorter in duration, maybe heavier menses, maybe more intermenstrual bleeding. All of this can happen in this perimenopausal transition. Again, limited utility of labs. They can be helpful in some folks if they had an ablation or a hysterectomy at a younger age, or if they have an IUD and are already kind of menstrually suppressed, you don't really have that to go off of. A couple of other abbreviations that you're going to see throughout here, and I think it's just important to understand kind of language and the words that we use. So in our world, we like to say menopausal hormone therapy, and we've really swung away from the concept of hormone replacement therapy. Hormone replacement therapy suggests that estrogen is a hormone that has to be replaced, and it doesn't have to be, but certainly if someone's quality of life is affected, there is a role for that. So we've tried to kind of introduce menopausal hormone therapy as opposed to HRT. Vasomotor symptoms, VMS, is kind of our shorthand for that, and you'll see that that's kind of one of the things that is measured most in research because it is relatively quantifiable. I can count the number of hot flashes where it's really hard to measure quality of sleep or cognitive changes. And then genital syndrome of menopause is kind of what we refer to as the local symptoms that happen at the vulva. So why do we care about menopause? So for a woman with a normal lifespan, 40% of their life is spent post-menopausal, and so that's a significant portion of their life. There's a huge economic impact with these changes in cognitive function, and it's estimated that $1.8 billion is lost due to lack or changes in productivity in this menopausal transition. So $1.8 billion is a lot of money. Health impact. So we see kind of, again, those worsening of all those other conditions, but I think what is really important and probably more specific to your population is the role of bone health and osteoporosis. So when we think about bone health, fracture prevention is probably the most important thing for long-term health and vitality. So even if someone eases through that menopausal transition without significant hot flashes, it has profound impact on the rest of their life when it comes to their bone health. We know people with hip fractures don't completely recover, and that changes their overall mortality. 1/3 of women with a hip fracture will recover completely, but about 20% of women with a hip fracture will die in the first 12 months after a fracture. So the goal is to prevent that first fracture. We have accelerated bone loss in the menopausal transition. So peak bone mass is typically achieved by age 30, and we're losing bone mass every single year, and the most rapid loss is in that perimenopausal period. So in your 40s, that is the most rapid bone density loss. And we have 15% of women are estimated to have osteoporosis by age 50, but it's honestly probably more than that because we're just not screening. So the current recommended guidelines for bone osteoporosis screening is a DEXA at age 65, and this is for average risk people. I would argue that your patients are probably higher risk and should be getting that DEXA scan even earlier, and I think we will probably see a shift in that guideline to have DEXA scans at an earlier age. So menopause and sickle cell disease. When I was kind of preparing this slide, I did a quick Google search just in PubMed and then kind of in our menopause journal space. There was one poster that was an abstract that was published, and in specific to sickle cell disease, there were 2 published articles with overall less than 50 women represented. So there's a huge gap in the literature, and my OBGYN heart is really happy hearing you guys talk about contraception and talk about fertility preservation, but we again have to realize this is half of a person's life, and this is something that is completely understudied and not understood as well. Women with, again, as we talked, women with sickle cell disease may enter that menopausal transition sooner due to medications, the chronic stress, certainly stem cell transplant with chemotherapy. And then we have unique hematologic risks, as you guys know, with sickle cell disease and menopausal hormone therapy, primarily VTE and the concern for cardiovascular risk. All right, so moving on to menopausal hormone therapy, what is it actually approved for, and what does social media say it's going to benefit? So menopausal hormone therapy from the FDA perspective is approved for moderate to severe vasomotor symptoms, moderate to severe genitourinary symptoms, prevention of osteoporosis in postmenopausal women, and early menopause. So premature ovarian insufficiency, POI, or early menopause, we define as age less than 40. So the absence of menstruation for 12 months, or again, FSH levels dictating that. What are contraindications to menopausal hormone therapy? So these are your absolute, well, I'd say some are relative, but these are our general contraindications. So when we think about cardiovascular risk, we really use the ASCVD risk calculator to really determine risk. I think a lot of times we actually overestimate people's cardiovascular risk and think they may not be a candidate for menopausal hormone therapy, but they actually are. So ASCVD is certainly going to keep in mind their hypertension, and if it's treated or not treated, age, race, and then their lipid profile. Unexplained or unevaluated vaginal bleeding is certainly something that needs to happen before we start someone on it. Untreated endometrial hyperplasia, again, this is not going to really be in your space but mine. Untreated or uncontrolled hypertension, chronic liver disease, active history of breast, endometrial, or hormone-sensitive cancers, and a history of VTE, stroke, or TIA. And then just a couple of other words that are thrown out there. So bioidentical is really a made-up word. It is not used in our space. It's really been a marketing tool to say, this hormone may be better than that. But there are bioidentical, if we use the word bioidentical, there are chemically similar compounds that are out there that we can prescribe that are not just from compounding pharmacies. Bioidentical has really been used in the integrative health space and the wellness space and these compounding pharmacies, but it's truly just a marketing term. That being said, there are some estrogens and progesterones that are better than others. When we think about estrogen, it really should be transdermal to reduce that risk of VTE. So, transdermal we give either by patch or gel. The most commonly used patch is Vival-Dot, or its kind of equivalence, which is changed twice a week. And then there's also a daily gel. This can be particularly helpful for folks that may have skin sensitivities to adhesives, and you'll know that pretty quickly when you're starting someone on it. Transdermal estradiol actually has a lower VTE risk than estrogen taken orally, and some studies actually do not show an increased risk of VTE, particularly with estradiol and, again, that transdermal route. Progestins, there are many, many different options with different side effect profiles and VTE risk. So here I kind of have an order of what we kind of classically think of what has the lowest VTE risk to the highest. So Prometrium, which is the brand name for micronized progesterone, chemically looks the same as what our own progesterone is, and we see a much lower side effect profile and a lower VTE risk with micronized progesterone. So that is usually our preferred progesterone, and that's given orally. Norethindrone acetate, which we'll use a lot for menstrual suppression, does have some VTE risk, and then medroxyprogesterone acetate, which is kind of what people most commonly use, actually out of all the progestins may have a higher VTE risk. Always kind of in the conversation around menopausal hormone therapy and this transition is we always need to consider the need for contraception. Just because someone's menstrual cycles are changing does not mean they can't get pregnant, and we always want pregnancies to be planned, desired, and certainly well counseled, particularly in the space of other comorbidities. I think also as doctors, we have kind of conflated the risks of menopausal hormone therapy with the risks of combined hormonal contraceptives. And they are very, very different. They are different types of estrogen, and they are different doses, and they're different routes. And so we really cannot use what we know for combined hormonal contraception in the MHT space. So the CDC has a medical eligibility criteria, which is very helpful for contraception for people with medical comorbidities, but that does not apply to menopausal hormone therapy because they're totally different types of hormones and routes. So general principles for menopausal hormone therapy is you want to start it within 10 years of the last menstrual period. Starting it beyond that is going to carry more risk, particularly cardiovascular, and that's really what the studies have shown us. And we're going to dig into the Women's Health Initiative because that was really what swung the pendulum away from more universal use. There's no guidelines on duration of use. However, generally speaking, we want the lowest effective dose for the shortest amount of time possible, but this is really not based on any data, and it should really be shared decision-making with the provider and the patient, and again, kind of a constant assessment of their risk factors and if they're still a good candidate for MHT. It should be estrogen and progestogen or progesterone if someone still has a uterus. Again, transdermal is preferred. And then you should always do risk stratification, which again, we use the ASCVD calculator primarily. So what is kind of the risk of VTE and cardiovascular risk? And how do we kind of talk about this to patients? Unfortunately, what we have from the FDA is really class labels. So when the FDA kind of gives black box warnings and things, they lump all hormones together. And as I've said before, not all hormones are created equal. Most studies also use different types of hormones than we actually use in real life. So most studies are using conjugated equine estrogen, so that's Premarin. So the historical context of Premarin is it's from pregnant horse urine. So pregnant mare urine, that's how they got Premarin. But this is a synthetic estrogen that is made and looks chemically different than what our own estrogen is in our body. And so most of us prefer to use estradiol, which again is going to be chemically similar to our own steroids that we produce. And then again, most studies are also using medroxyprogesterone acetate, which we abbreviate MPA, which arguably has a higher VTE risk. There's also a timing hypothesis with MHT. So the thought is that as women, we generally have better cholesterol profiles than men, and as we go through this menopausal transition, that cholesterol profile shifts. And so to have the cardiovascular benefit of MHT, it's really best to start it as close to that menopausal transition as possible. And this is really played out in the literature as well, in that in women that start it later in life, in your 60s, you have a higher cardiovascular risk, and this is kind of what swung the pendulum away from use, particularly with the Women's Health Initiative. So the Women's Health Initiative was kind of the sentinel piece in our world that really changed the landscape of hormone therapy. The study was primarily designed to understand the primary prevention of coronary heart disease, and the study was incredibly flawed. It is not how we actually use hormones. It was stopped early at 5 years due to increased cardiovascular risk as well as an increased risk of breast cancer. But when you actually look at the data and the study participants, the average age of a person starting hormone therapy in this study was 63 years old. That is not how we start menopausal hormone therapy. We're starting it much closer generally in a woman in their 40s or early 50s. And you guys all know that our risk of breast cancer, our risk of cardiovascular disease is going to increase just age-related risk. They also use conjugated equine estrogen and again medroxyprogesterone acetate, which have higher VTE risk and higher cardiovascular risk, and again is not really what is used or best practice. So digging in to the Women's Health Initiative a little bit more, you can see the impact of it. So in the 90s, I was in high school, hormone therapy was used pretty universally. You can see here the use, I wouldn't say pretty universally, but about 30% of women were on some form of hormone replacement. After the Women's Health Initiative, it plummeted. So you can see in 2000s. And so there's a swath of a whole generation of women that missed out on the benefits of menopausal hormone therapy that are currently in their 70s and 80s and probably having more osteoporosis. And I think only time will tell as we look at that retrospective data. However, again, as we understand the Women's Health Initiative, there's also some benefits. So this is a busy slide here, but the purple is menopausal hormone therapy, and the green is placebo. And when we stratify by age, you can see on your left, there is risk reduction in all groups, and there is a decrease in all-cause mortality in people that use menopausal hormone therapy. The only significance is certainly an increase of stroke and PE, which we would expect in people taking estrogen. But when we actually look at the absolute risk, which I'll show you on the next slide, it is really not that increased. And so again, it was these older women in the 60s and in their 70s that really drove kind of those studies' outcomes and got the study unfortunately halted, and that really kind of swung the pendulum away from hormone therapy. So this is just another way to look at it when we kind of look at kind of the risk of cancers in estrogen alone and then estrogen plus progesterone. So the estrogen alone arm would be folks that have had a hysterectomy. So you can see here there is a decreased risk in coronary heart disease, stroke, breast cancer, colorectal cancer, all cancers, all fractures, death from any cause, and diabetes in people that used menopausal hormone therapy, estrogen alone. So there's actually a decreased risk of breast cancer. So again, this is really helpful to kind of explain that, because I think that's a big driver for why people don't want to use it, is the fear of breast cancer. And then when we look at progesterone, we did see kind of an increased risk of breast cancer with the addition of progesterone. So we really think progesterone is the bigger driver for that risk, but we still see kind of benefit in those spaces. So if we look here, this is the, 10, for example, on deep vein thrombosis, 10 women had an increased risk, but this is out of 10,000 women. So the takeaway home is the absolute risk is increased by no more than 1 per 1,000. And so, yes, it's increased, but it is quite a negligible risk when we have significant added benefit, particularly for bone density and all-cause mortality. So what about sickle cell disease? Again, we just don't know. If there's no contraindications, so I would say history of VT or stroke, in my opinion, as a menopause practitioner, I do think menopausal hormone therapy would be an option. If they're on anticoagulation, let's say they've had a VT and they're miserable, if they're on anticoagulation, I would argue that they probably still could be on estrogen if they're adequately anticoagulated. We have limited case reports of hormones with gender affirming care, so male to female, and in people with sickle cell disease. And there was use of it. I think I saw a case report of 3 people. There was no increased harm, no increased risk of VTE in male to female transgender people. And arguably, these are going to be much higher doses of estrogen that they're using than what we would be using for a cis female. So when to stop MHT, again, we talked about the shortest duration. Prior recommendations had recommended to stop at age 65, but this isn't really supported by ACOG or the Menopause Society. There's really no strong recommendation for abrupt versus tapered stop, though the taper may be more tolerable as far as management of symptoms. However, long-term use of topical therapy or vaginal estrogen for the genitourinary syndrome of menopause is very safe, and we'll talk one slide about that as well. So while hot flashes, sleep disturbance, cognitive changes, those tend to get better through the menopausal transition. Average duration of those tend to be about 7 to 10 years. What gets worse is our local symptoms. And so we see an increase in vaginal dryness, increased frequency of UTIs, pain with intercourse, increased urinary incontinence, and the gold standard treatment is going to be vaginal estrogen. There's really no person that can't use vaginal estrogen. We actually use it for breast cancer survivors once their disease has been stable, certainly in coordination with their oncologist. You can use it in someone with a history of VTE because there are really not significant levels that are obtained with just local use. And then I would be remiss if we don't share kind of non-hormonal options. However, they just don't compare at all to efficacy when it comes to estrogen. So certainly our SSRIs, gabapentin can be used, and we can see in some studies reduction. But again, if you compare this to estrogen, it's going to pale in comparison to how people feel. And certainly we're not getting any bone health benefit from these non-hormonal options. The newest player on the field is fezolinetant or Veozah. So this acts centrally on neurokinin and GABA receptors to really help with that temperature modulation. So particularly for hot flashes, this has some pretty good success. However, it's a newer medication, so you're going to have cost, prior authorization, and all those hoops that we're used to jumping through. But if you do have someone that's contraindicated for estrogen, Veozah can be a nice adjunct. And then certainly disparities is always important to talk about. Black women are underrepresented in most studies in the menopause space, and certainly I'm sure for a lot of other. However, we know that in our observational studies, which the biggest one was the SWAN study, which looked at multiple ethnicities, Black women actually have more intense symptoms, and they are 50% less likely to be counseled and or to use MHT. It's going to be hard to understand if that's because if there were contraindications, but I suspect there's probably some bias in there and that they weren't counseled nor offered or even screened for it. All right, so kind of moving on to some cases, we'll just kind of walk through some of them, and then hopefully we'll have a little bit of time for questions. I think I'm doing okay on time. So our first case, a 46-year-old with severe perimenopause and climacteric. So climacteric is the old word for menopausal symptoms, including joint pain, brain fog, mood swings, weight gain, sleep disruption, urinary, it should be incontinence, and night sweats. Her typical pain from her sickle cell disease has worsened in the last 2 years despite no changes to her therapy and otherwise compliance. She has hypertension that's well controlled on lisinopril. All right, so our approach, the first thing I would do would be assess her cardiovascular risk. So I'm looking for her last lipid profile. I'm making sure that she's been screened for diabetes, and then I'm plugging her into the ASCVD calculator. If she is kind of risk stratifies low, which kind of our ASCVD risk that we are okay using hormone replacement is 5% risk or less. 5 to 10% is shared decision making, really kind of understanding that with the patient. Greater than 10% ASCVD risk would really be a non-starter for menopausal hormone therapy. I'm going to assess her need for contraception. So I said that she was 46. Very possible to still get pregnant at 46. And so if she is not contracepting, we definitely want to talk to her about that. What can be really helpful in the perimenopausal group, so in those 40s, is a levonorgestrel IUD, so a progestin-containing IUD. This does not carry VTE risk like other forms of contraception. It's a very effective form of contraception, as well as it provides that endometrial protection. And we know that the hormonal IUD can be very powerful at minimizing menstrual changes. About 40% of women will have amenorrhea with a hormonal IUD, but about 80 to 90% report a significant reduction in their bleeding. So as their periods are getting wild, the IUD is a nice place. And then I would offer this person transdermal estrogen. There's a lot of different approaches to what dose you start at. I typically start kind of somewhere in the middle. Kind of the standard dose for Vivel-Dot or transdermal estrogen is 0.05 milligrams, and that has different kind of comparisons to other forms of estrogen. But I would typically start there, and I would have room to go up or go down. Some people are conservative and start at that lowest dose, but I generally want people to feel better, and if they start at that lowest dose and they don't feel better, I may not be able to kind of talk them into continuing with menopausal hormone therapy. All right. So next case, a 54-year-old with sickle cell disease presents with worsening insomnia. Her hot flashes are tolerable, but sleep quality has declined. This has caused significant decreased productivity at work, is contributing to missing medications. Her LMP was 5 years ago. She does have a history of stroke, and let's say she has a history of VTE, and she's hypertensive. So for this person, estrogen would be contraindicated. So this is someone that if they were having hot flashes, I would offer some of these newer options, Veoza, or consider SSRIs, or potentially gabapentin. However, for the sleep, what can be really powerful is that micronized progesterone. So micronized progesterone or prometrium, in addition to its progesterone effect on the endometrium, it actually is very helpful for sleep. And that's kind of the unique thing about it, and we do not have VTE risk. So it would be reasonable to just offer her progesterone only, again with that nightly prometrium. And again, it's not habit forming. So again, we know that a lot of people have chronic pain. They may be on opioids or other substances. And so we want to kind of avoid polypharmacy with this. Prometrium is not habit forming, and again, can be very powerful for sleep. Also keep in mind sleep studies. We know that obstructive sleep apnea is very underdiagnosed as well, and this also tends to have an increased incidence in the menopausal transition. All right, in our last case, a 61 presents to your office for continued medical management of her comorbidities. In the past 3 years, she's had 6 UTIs, 2 episodes of urosepsis that were hospitalization. What role would MHT have for her? This is probably one area that I think most people should be pretty comfortable, because you really can't hurt anyone, is considering the role of vaginal estrogen. So the decline in estrogen affects, again, all parts of our body, but particularly locally to the vulva. It changes that uroepithelium. And so we see an increased risk of UTIs and certainly pain with intimacy and everything that goes around with vaginal dryness. And so for her, I would consider local estrogen therapy, either using a cream, a tablet, or a ring. There's a lot of different ways that we can give estrogen vaginally, and it's really just patient preference. It does not require a progestin because, again, we're using small levels. That's not really reaching significant levels in the blood to kind of change the endometrium. And again, she's 61, so I'm assuming she's greater than 10 years probably from her last menstrual period. So systemic hormones really would not be an option for her. But again, local hormones, local estrogen can be started at any time and continued indefinitely. All right, so I think that's my last case. And then one thing that I think is really important, and probably my good take-home point, is even though menopause is really hard, I'm in the thick of it now and probably haven't even hit the peak of my symptoms, I think there is light at the end of the tunnel. And I guess I would say for women in the room and all of us as providers, there's usually 3 points in a woman's life that we mark. So we talk about menarche, maternity, and menopause. And again, menopause is covering a longer duration of their life. So I think a good kind of thing to give patients hope, to give us hope as women is, menarche is when we say a girl becomes a woman. And again, I don't really like that, but it's said. So menarche is when girls become a woman. Maternity is when a woman becomes a mother. And menopause is when a woman becomes herself. And so we are losing kind of a lot of arguably the crap that comes with our menstrual cycle. And with that comes a lot of wisdom, experience, and really just a new season. And so I would, while it's tough and we have things to ease the transition, I think it's also very exciting. And, again, we have decades ahead of us. So that is all I have. Some good resources. I guess if we can go back a slide. Good resources would be the menopause.org. So that links to the Menopause Society. There you can find a practitioner that is certified in, so at the bottom, you can find a certified menopause practitioner, particularly people with complex health conditions. Even their own OBGYN is probably going to not be well-versed in hormone therapy. The reality is that after the Women's Health Initiative, education on menopause totally plummeted. So, most OBGYNs probably don't have a level of comfort around menopausal hormone therapy, despite kind of a benefit. I think the pendulum is swinging back, but I think especially folks with complex conditions, I would explore a certified practitioner, and hopefully they can understand and navigate those risks a little bit more for your patients. So that is it. Under time.
Thank you so much for that presentation. Can you speak a little bit about using testosterone for hormone replacement in menopause? I just saw a patient who's about 65. She's a late diagnosis of sickle cell disease, and I think she found a menopause practitioner somewhere. She's on this combination of topical estrogen, estradiol, which sounds good. She has progesterone and also testosterone on there. And so it's very difficult to decide sort of how to guide patient. She has no risk factors that I was worried about otherwise.
Yeah, I mean, testosterone is even more of the Wild West than current menopause therapy. And I suspect she probably found a provider, but they're not a certified menopause practitioner, and probably more in the wellness, functional medicine space. Testosterone definitely has benefits. And in our literature, it seems to be primarily related to hypoactive sexual desire, decreased libido. In the menopausal, in postmenopausal women, supplementing with testosterone has shown to increase libido. It's one of the only things we have that can do that. Obviously, sexuality in women is very complex, a lot of variables that go into it. A lot of the claims made around testosterone, particularly on social media, are going to be like increased cognitive function, bone health. That is actually nothing in the data regarding that. Testosterone currently is not FDA approved for women, with the exception, obviously, of transgender people. And so if you're using testosterone, a lot of times we're using compounding pharmacies to keep costs down. I would say I do prescribe testosterone, but usually I like to maximize our traditional therapies first, because a lot of people can feel better just on estrogen and progesterone. And so usually I will do that for anywhere from 3 to 9 months. And if they're still having complaints, particularly around libido, and I would say maybe a little bit with fatigue, if we haven't made progress there, then I would consider it. What is really important with testosterone is you do check levels for that, because people can get super therapeutic levels of testosterone, and that can have irreversible changes to their hair pattern, clitoral growth, jawline, voice changes. And so we don't want to kind of approach those kind of traditionally negative symptoms for women. And so we would check their levels anywhere from every 2 to 3 months. Once they're on a stable dose, we can leave them there and probably check it 1 to 2 times a year. But your goal is to try to get it in physiologic range, which is going to be like 25 to 75 of your testosterone levels. If you're getting above 100, you're kind of getting into territory with significant side effects.
I'll just come up here. So thank you. That was a wonderful talk. I'm so glad that you put that UTI slide up there, because I have had some more mature women who have the recurrent UTIs, send them to OBGYN, who then says, see urology, and I'm in this cycle of things and breaking. So I think it did not occur to me that people in the field may be lacking some of this, and so finding this certified, I think that was like really, really helpful, because the women are going in this loop of go to urology, and then they start doing all these things when you first started with their OBGYN. So I think that was a helpful comment. I don't know if you have steps on how to bypass things a little easier or quit putting them through that.
I mean, I really think vaginal estrogen is very safe, and I think most people should be empowered to prescribe it. There's really no contraindications, with the exception of active breast cancer, that people can't use it as first line. And vaginal estrogen is pretty cheap. There's a couple of different ways to give it, as I mentioned. The simplest way, if people don't want mess, would be Vagifem, which is a tablet. It's a 10 microgram tablet of ethinyl estradiol, and so that is placed in the vagina. Typically, when we start estrogen vaginally, we kind of do a ramp-up period to kind of really help with the epithelium. So we'll do it usually nightly for 1 to 2 weeks, and then we'll kind of just maintain at 2 to 3 times a week. And this goes for all formulations. So Vagifem is super easy. Other is estrase, which is just plain estradiol cream, and that is usually 1 gram in the vagina nightly. Then I usually like the cream because people can tailor it. They can place it in the vagina, but they can also use it around the vulva or urethra, other spots if there's more local symptoms. And then if someone, has decreased mobility or is unable to do these things on a regular basis, there's a vaginal ring that's placed every 3 months, and some people actually have their provider take it in and take it out. That tends to be a little bit more costly and doesn't have as good insurance coverage for that. But honestly, I really think you can be empowered to prescribe it yourself if it's a vaginal formulation. And again, there's OBGYNs are undereducated in this, particularly from the result of the WHI. So, anyone, I would say, probably, honestly, all OBGYNs. We're really trying to shift it in our residency program, but it's a huge, huge gap, even among academicians.
Very informative talk. So you mentioned that the risk for VTE and cancer is more towards the 60 plus years. But if we start prescribing it earlier, like 50, are we just shifting that risk earlier or no?
Yeah, I think it's always hard to know what's age-related risk with malignancy and what is actually drug risk. Particularly in breast cancer, there does seem to be potentially a duration of exposure where 5 years, greater than 5 years of hormone therapy may be associated with an increased risk. However, if we're actually looking at the data, there's probably higher risk with regular alcohol use, which we've deemed very socially acceptable, than there is with some of these therapies. So I would say I don't know we have the clear data to say what is age-related risk and time-dependent versus hormones. But again, I think that the bone health is really the driver when we think about longevity and vitality for women in kind of their second half of life. Sorry if that didn't answer your question as well.
Thank you.
May well overlap with their sickle cell symptoms, and understanding when the right time to consider that as a potential source of symptoms.
I think if I would consider it probably earlier than what we typically do, even before their periods are stopping completely. So what there's a complete lack of data in the menopause space, and there's even more so in the perimenopause space. But you can still use menopausal hormone therapy for perimenopausal people, it's just kind of nuance of what their menstrual cycles are doing and how we manage that. But again, if we think about bone health and the rapid loss, starting estrogen in the 40s is probably better long-term than starting it later when they've already had loss. So I would say if their menstrual cycles are changing, they're skipping or they're shorter cycles, I would say probably finding someone at that point as opposed to it's been 12 months and I haven't had a period, I'm miserable with hot flashes. And I think some of it is also normalizing conversation around it and kind of some anticipatory guidance. So as soon as I have someone that I'm seeing for an annual exam and they're in their late 30s, I'm talking about, okay, this is what you may expect. If this is affecting your quality of life, please come and see me and we'll kind of talk through options. And then certainly we want to exclude the obvious. We want to screen for thyroid disorders, screen for diabetes, and making sure that all of their other comorbidities are optimized. In my experience, it's not hard to get covered. Estrase, vaginal estrogen, estradiol cream is usually pretty cheap. If your insurance doesn't cover it, GoodRx usually brings the cost down pretty significantly. So really the prescriber from the insurance standpoint shouldn't matter. And I think there's usually pretty cost-effective options out there.
Hi, I see recurrent UTI as a precipitating factor for painful events for patients. And so I was just wondering if any of like the contraceptive methods that we're recommending might be causing something similar to GSM, and if there are younger women who might benefit from topical estrogen.
Yeah, absolutely. And I think we're seeing a lot of kind of practice shifts towards that. We don't really have great data on it yet, but I would say in the kind of reproductive age person, we do know that combined hormonal contraceptives, which your patients probably aren't on as much, is going to, even though it has estrogen in it, is still going to lower their overall physiologic levels of estrogen, and so they may have changes. There's some early studies out there with the progesterone IUD in that local progesterone inhibiting kind of the local estrogen effect. But I would probably use our experience in postpartum people with estrogen and vaginal dryness in that hormonal state of potentially kind of giving estrogen cream, even if they're still menstruating or if they're on contraception. Again, the vaginal estrogen is not enough for contraception. It shouldn't impact the efficacy of their contraceptive method. So I definitely think it's something to potentially explore if they are having recurrent UTIs. Exam may be consistent with a hypoestrogenic state. I definitely think it would be something to explore. And we use in the pediatric population as well before they hit menopause if they're having irritation or other symptoms too. Yeah, Depo, I would say the same way. Depo is probably even more profound. So Depo-Provera is going to shut down the HPO axis, certainly more than the IUD, or certainly more than Nexplanon as the other kind of progestin-only contraceptive method. So Depo is probably going to shut things down even more. So I would definitely consider it.
Hi. We're working on a lifespan paper in sickle cell disease, and we have a section on post-reproduction menopause hormonal therapy and premature ovarian insufficiency. What role should the hematologists play, and how can they collaborate with menopause practitioners to help counsel patients?
So I would say, again, if they meet the diagnosis of premature ovarian insufficiency, would be kind of, again, the classic definition of menopause, but age less than 40, they absolutely should be on some form of MHT for their bone health and cardiovascular health. So if they're an appropriate candidate. Where I think you guys can come into play is if you're seeing them more frequently, I would say really that bone density screening and doing that, just keeping that on your radar and doing that, really at the age of diagnosis.